to present on workforce issues today. I will share with you, we are also looking forward to hearing from others, and in particular, Gina. So you may recall we presented our strategic plan to you a year or two ago as far as KDADS, and when we came in to KDADS again, Secretary Howard and I and others, we did include workforce concerns in our strategic planning document. Our bullets include assessing the current service delivery workforce status, valuing direct care providers more highly, partnering with community college and secondary educational institutions to reinforce, identify technical assistance, create internships, quantify the extent to which HRSA loan payments are utilized, educate providers on staff retention options. I will share with you, we have done some of this work. We haven't had as much opportunity to put resources behind it the way we still want to, and I believe that the way we're still going to need to in the future. So, but I did want to make sure and let you all know it is on our radar, to say the least, the concerns we all have about the workforce. And here's why. The networks that we are connected with and to rely heavily on hands-on workforce. So we've got direct support professionals in our IDD community. We've got certified nurse aides and medication aides in our nursing facilities and adult care homes. We have direct service workers in our community-based networks. We've got personal care attendants across HCBS. We've got home health aides, behavioral health workers, case managers, healthcare professionals, and others. So our networks are supported by this workforce, to say the least. And here's why it matters. And I'm going to start with seniors initially. The graying of America is happening. In less than 2 decades, and actually it's only 13 years, the graying of America will be inescapable. For the first time in our nation's history, in 2034, which isn't really that far away, the Census Bureau projects that older adults will actually edge out children in population size for the first time in our history. So the driving force for this increase is, as you all know, it's the baby boomers. It's me, it's us. We will all turn 65 by the time we get to 2029. And then what's even more startling is the oldest of the baby boomers will actually turn 85 by 2031. So we are now talking about less than 2 decades, and the baby boomer impact will be upon us. Very specific to COVID, although I don't want to spend a lot of time on this presentation specific to COVID, but just to let you all know, COVID did impact workforce significantly. Nursing facilities needed more staff, and instead they were having difficulty hiring staff and keeping staff. KDADS did respond to guidance that was being issued from CMS about some flexibilities and some options. We did request of the governor's office for some executive orders, and those did materialize. We did what we could during this COVID pandemic to speed up our processes. So allow individuals to move through the process of becoming a certified nurse aide in a CMA quicker than we would have ever anticipated. In fact, you'll see on this next slide that we shifted 90-hour course to 8-hour course for temporary aides. I mean, we just simply had to accelerate some of our courses in order to get even more CNAs available as temporary aides to nursing facilities. I'm sure Representative Carpenter, as you mentioned throughout the entire session, you're going to hear staffing concerns from, we believe, all of our networks, but the nursing facilities and adult care homes in particular. And this just shares with you some of the actions we took very specific to COVID. These are just some charts, again, that capture the outcomes of those measures. You can see that in March of 20, this is the number of newly certified. Then we did take a dip during April and May with COVID, and then we brought those numbers back up as quickly as we could to try to get CNAs certified, and that did happen. This next chart, the COVID numbers are actually in orange with this particular chart. It just gives you a comparison to where we were in 19, which would be a normal year, compared to what we experienced in 2020. And you can see the significant drop in April and May, and then June and July, we got a little bit back to normal. And then November and December, we aren't quite where we were the year before, but at least it's not the same as it was in May, which was so unsettling. We just had to take action quickly, and we did. This just gives you a comparison of the number of CNA courses. It's a good comparison. You can see the courses were still being made available. And then, unless there are questions specific to the nursing facilities, I'll transition into the behavioral health world and what we are hearing and experiencing there. The Mental Health Modernization and Reform Report, which is a product from a group that was pulled together, an extensive group that was pulled together, work group, this past summer. That particular modernization and reform report does include workforce recommendations. So we just simply went out to that report and created these particular slides. According to that report, 99 of the 105 Kansas counties are federally recognized as a mental health professional shortage area. So that's 94.3% of our state meet the criteria of being in a workforce shortage situation. So primary concerns with mental health workforce development are competition for quality staff. You're going to hear that across all of our networks. Inadequate funding, that's not going to surprise you at all to hear that. Use of telemedicine, which I do think that is actually a positive note out of COVID when it comes to mental health and behavioral health, is that telemedicine was kicked into gear really quickly to respond to this network. And we have had some positive feedback on telemedicine. NCO network adequacy requirements for licensing being higher than other states. So those are the concerns expressed. And then the workforce recommendations do include some more immediate action, where possibly the number of clinical supervision hours could be reduced to obtain a clinical license. We could require a study to be conducted by KDADS with an educational institution to explore strategies to increase the number of psychiatrists, child psychiatrists, and psychiatric nurses. There were also some recommendations about adequate compensation and reimbursement rates for these particular professionals. And then another, well, I don't want to say a footnote, but another comment is the report notes that certified community behavioral health clinics are becoming available across the nation, including Missouri and Oklahoma. And these particular clinics would be funded differently by CanCare than what the 26 CMHCs, how they are funded now. And then we also make a note that we continue to support Medicaid expansion to leverage additional federal dollars. In HCBS, what I will say, the community-based world in general, with their workforce, we found this information from the US Key Facts, and it too is unsettling that HCBS direct service workers who do provide a significant amount of the actual hands-on care across our nation, they are largely female. median age is 47, and these are national numbers, not Kansas specific. 6 out of 10 identify as part of a minority group. Over 25% across the nation were born outside of the United States. This includes your personal care attendants, or home health aides, nursing assistants, which I mentioned all those in the earlier slide. Wages are oftentimes nearly stagnant. The median hourly wage is $11.03. 2 out of every 5 work part-time, predominantly government funded, for example, Medicaid. Nearly 7 out of 10 work for not-for-profit, and then more than half receive some form of public assistance themselves. So that is from our vantage point, Mr. Chairman and members of the committee. I mean, I just hesitate to present today with just doom and gloom, and I hate to do that. I hesitate to do that. I felt like yesterday's conversation about Senior Care Act was so upbeat and promising, if you will, where today's presentation is it's unsettling. We are going to have workforce issues, we believe, with all of our networks, and we'll continue to work with you all on solutions. And I'll be honest with you, we'll have to continue to work closely with our networks to do what we can do to support them. So with that, I will be happy to answer any questions if I can. More than anything, we just wanted to provide you with our concerns and some data. And I will say this, I heard the other day on the news, I don't know if you all heard it, but as a result of COVID, women are leaving the workforce at a rate 4 times greater rate than men. That women are just leaving the workforce. So that's not good. That's not good for us at all. So with that, Mr. Chairman, I will stop and answer any questions if I can.
Representative Ballard.
Mr. Chairman, Janice, the comment you just made about women leaving the workforce, yes, that is true. And, you know, statistics are showing that as a result of COVID and because of schools being closed, child care facilities not being available, or just being afraid to have your children in the middle of all of this, they are leaving, but basically the problem has always been they have been underpaid. And they have been working in the lowest paid jobs in this country, service-oriented, so that when you put all of that with COVID and everything else, and they have children especially, they have to stay home because there's no one else to take care of them, which creates a problem because over 50% of our population are single women heads of households. So that's creating another problem because there's no one else to take care of them, which then creates a problem for social, you know, security down the road. Or will they have enough in order to be, or will this government have to take care of these women? So there's lots of reasons why, and they're not just leaving because they really want to, or they want to go home to have children, where some people that have worked for years and years and years have chosen now to go home and have their children. They're in an unfortunate position that they really don't have a choice. Could you comment on that?
Other than just to say, I mean, I would agree with you. I was surprised to hear the stat that women are leaving the workforce 4 times greater rate than men. I think that is disturbing. And again, Representative Ballard, particularly for our agency, when our networks rely so heavily on women as our primary caregivers. So,
Representative Lynn.
Thank you, Mr. Chair. I was struck by the change in hours for the CNA's training, the 90 hours to 8 hours. And I guess my question is, how did that affect the quality of care?
And let me say then this, Representative Lynn, there were concerns, and these are temporary aids, so it's not the same. They didn't walk away with the CNA the certified nurse aid. They were temporary aids who needed to then have oversight. So these were just individuals who could temporarily come in and assist with some oversight. And Scott Bruner, who's our other deputy secretary, who's over the survey and certification group, he will be testifying next week. So Scott would also be happy to answer any additional details about, the impact of the CNAs. We have certainly received positive feedback from the nursing facility associations, trade association in general, that they absolutely needed the workforce. They absolutely needed the flexibility. And then we needed to make sure there was oversight within the facility of those temporary aids.
If I may, Mr. Chair. Then you're suggesting they were able to retain a lot of those workers, and will they be required to finish that training to receive their actual certification?
If they choose, right, after the EO expires, and if they choose to stay in the business, and yes, they would then be expected to. And Scott can provide even more details, because there has been a significant amount of conversation surrounding this option. But overall, we do believe it has served Kansans well who reside in facilities, and we feel comfortable that the oversight is there. So if an individual chooses to stay, then it's my understanding they would then have to complete the certification requirements once the pandemic expires.
Thank you, Mr. Chair.
Committee, further questions? Oh, I see Representative Ruiz.
Thank you, Mr. Chair. Thank you so much for your presentation. Do you happen to know what is the average hourly salary of a CNA worker?
Here in Kansas?
Yes.
You know what? That's a good question. I do not know off the top of my head. I would have said about $11, but I may be wrong on that. So let us double check on that and see if we can find some Kansas specific data. I do think it's out there. The trade associations for years actually generated a survey of their salaries for their membership, which is nursing facilities, but I don't know if they still do that. So let me double check, Representative Ruiz, and see if I can find that for you.
And also what, the temporary workers, were they given some kind of a differential in their hourly, rate to be able to attract them to work temporarily? I'd like to know if there's been a difference with that.
Okay, and I don't know if we have data to track that, but we can check.
Okay, thank you.
I will share with you, Representative Ruiz, we will know much more along those lines once nursing facilities submit their cost reports. So, which won't be until the end of February, and we'll know more this summer about what COVID actually cost and what the salaries were and the differentials for it. So we may not have your second question data available quite yet, but we will this summer.
Wonderful. Thank you. Thank you, Mr. Chair.
Representative Concanon.
Thank you, Mr. Chair. My question is regarding telemedicine. And I'm kind of wondering what all you use telemedicine for. I think the obvious purpose would be doctor's appointments, but what I'm asking is if there are things that I haven't thought of. And also then, I'm wondering what you're anticipating once the emergency order expires, and we lose that part of telemedicine. The horse is out of the barn. That'll be hard to back up and go without telemedicine again. So I'm wondering what kind of legislation we might need in order to go on.
Yes, and so just to, good question. So, believe it or not, Representative Concanon, even PT, OT, and speech therapy were given the opportunity to try telemedicine, believe it or not. So, we heard some good feedback that overall it worked well. That, and I don't know that the future of that opportunity, but I will share with you definitely doctor's visits, psychiatric visits. I mean, just a lot of communication with even case managers. So in the behavioral health world, definitely just communication opportunities in general, whether it was a case manager, psychiatric visit, whatever it was, telemedicine, telehealth was definitely exercised heavily and significantly and fairly successfully. And then on the HCBS side, as I mentioned, physical therapy, occupational therapy, and speech therapy, we even connected, allowed our providers to connect with telehealth and telemedicine. So we think overall it was, we think overall it forced us to consider technology in our service delivery systems. And I think that, and I think our future will include even more. I don't see, Representative Concanon, that much of this being rolled back, except for maybe on some of the therapies. The MCOs are helping us make assessments. Our providers are providing us their insight. We're hearing from consumers whether they felt connected with telemedicine. I think there's been a survey generated, but definitely Medicaid Director Sarah Fertig is very, very insightful when it comes to the future as far as what we're going to need to do. So I would expect KDH&E to be presenting to you what they envision telehealth and telemedicine might look like that is more solidified. And I do think you'll be hearing from KDH&E and even from us in future presentations about telehealth and telemedicine. I think it's here to stay for a bulk of the services that we delivered during the pandemic. I think.
Thank you, Mr. Chair.
Yeah, it's actually been if there's been an upside, and I don't really know that there has been an upside to this pandemic, to be honest with you, but if there's been one upside, it's probably telehealth and telemedicine and the fact that it can work.
Representative Ballard.
Thank you, Mr. Chairman. You know, I'm thinking about your presentation yesterday when we talked about the Senior Services Act and everything else. And I was just thinking, we just talked about more women leaving the workforce. Well, that's another issue there because we talked about 900 people there, but there's a lot more than that, but we don't have enough money to cover. So
Right.
you have a lot of women that even though their children may be old enough and in college, they are now responsible for their parents, their mom and their dad in the process. So they sometimes have to give up their job in order to take care of them because the services are not available for them. And we talked yesterday about that brochure that we had for many years that's out there. That's one more reason why I will ask you to please look and see, do we still have that brochure? Because that will tell people what some of those services are that are available to them. And to have women at this stage leaving the workforce when we have worked for so many years to get them into the workforce, into good paying jobs,
Right.
and now it's reverting to not having that at all for lots of reasons, but mostly either because of children or parents, or because they have lost their jobs because those jobs no longer exist. And we don't have training or replacement for them. And so, you know, so it's funny that we're talking about that now, when yesterday I was just touching on the other. But I can think of 3 of my real good friends that took early retirement
Yeah.
this year because their parents did not have anyone to take care of them and they felt obligated to do it. And their brothers didn't do it, but the daughters did.
Yeah. So Representative Ballard, if I may just make a couple of plugs here, if you don't mind, and I'm going to piggyback on to what you and Representative Concanon have just mentioned. So I'm going to plug Monty Kaufman's telehealth that he has been, I don't want to say experimenting with because it's no longer an experiment. He has proven that some of his technology that he's incorporated into the HCBS world for individuals with physical disabilities, it works well. So if you have an opportunity to ask Monty Kaufman to come present, he would be happy to do so on what he's done for home and community-based customers, his clients down in Southeast Kansas. He's also working closely with the MCOs. Secondly, we have had conversations with the MCOs about smart homes. I mean, I'll share with you, years ago, I was at a conference and we started talking about refrigerators and can we have sensors on our refrigerators and our new smart homes that would allow a senior to have a typical pattern captured in like a ADT type system, that if my mother doesn't go to the refrigerator at 9 o'clock on a Monday morning like she typically does every single day, then I as a caregiver could be alerted to that. I could be alerted as a caregiver across town or across the state, hey, your mom didn't open her refrigerator today at 9 o'clock. You might just want to text her or check on her real quickly. So there are future opportunities that I think will link directly to our smart homes. To be honest with you, I do think that is going to be part of our future. Our homes will help inform our caregivers, whether they're paid caregivers or non-paid caregivers. I do think our smart homes are going to start allowing us to be monitored, if you will, in a very autonomous kind of way, and yet still feel connected. That is coming. The technology is already out there. It'll just be a question of how comfortable are we that our movements within our homes may be monitored so that someone else can be informed if we don't happen to get up that morning or if we have difficulty getting up. So I definitely do think that's the future, Representative Ballard. I think Representative Concanon, there's no question between telehealth, telemedicine, and smart home technology, we are going to be moving in that direction. But we're still going to need hands-on help. We're still going to need hands-on help.
Thank you. Thank you, Mr. Chairman.
Very good. And committee, I know that the Health Committee is working on a telehealth bill that came out of our modernization health deal, and it'll be coming out sometime this session. I know they're working on, I talked to Chairman Landwehr today about that. And so they are working on a telehealth bill that hopefully encompasses a lot of things that we were just talking about. So committee, we do have another guest here, Jean Ernvey, and we'll turn it over to her just in a little bit. But I want to just kind of touch base with you as far as this is overwhelming and can be very overwhelming, but we have to start somewhere, and we have to keep the fire under this issue in order to get it going. And I had a conversation with Gina earlier this year, and I said, Gina, we need to try to, do a bullet or something that we can accomplish, because when you start talking about it and then you see Janice's presentation, it's so overwhelming that pretty soon you're just like, throw up your hands because it's such a great big thing. No excuse. There is no excuse for not addressing these issues however we can. So that's why you continually hear me talk about workforce development, workforce. We hear it all the time, and people are going to get tired of hearing me say it, but the bottom line is we've got to address this issue in little bites, however we can. So, committee, are there any further questions? Representative Howard.
Thank you, Mr. Chair. Can you hear me?
Yep, we can.
Okay. My concern is this. Centers on Workforce. We had a stimulus from the federal government. We had 2 different unemployments coming in. Did that affect your workforce? Because I was going to the hospital once a month for special treatments during this whole time. And at St. Francis Hospital in Wichita, the people that were servicing me, the nurses and stuff, there was a big shortage. And then once the stimulus ran out for them, they all showed back up for work. Is that what you were seeing, or have you tracked that or asked those questions?
No, we haven't tracked the impact of the stimulus on our networks. No, we have not, and we did not. What we were tracking instead was just simply the impact of COVID on nursing facilities. That without question, it was a difficult time and continues to be a difficult time for nursing facilities across the state and across the nation, and maintaining staffing because of COVID fears was our biggest concern, that some staff just simply weren't comfortable coming back into the institutional environment because of COVID running so rampant with nursing facilities across the nation. So no, we did not hone in on stimulus impact. We were more concerned just in general about COVID impact for our Kansas residents and nursing facilities, and then hoping that staff would continue to come to work. Some did, some didn't, to be honest with you. So.
Okay, thank you.
Okay. Representative Donahoe.
Can they hear me? One of the things I'm wondering about is minimum wage, what impact that's going to have on this industry. You know, whether that will allow people to make enough money to stay, or will it be too costly for the people that own the homes and everything?
I think that's a good question, and I don't have necessarily a complete answer for you by any stretch of the imagination, but the $11.03 average across the nation for a bulk of this workforce would increase. I believe I read that the proposed minimum wage, I think I saw $15 an hour. So, I mean, that would be significant to say the least, but for this particular workforce, my guess is a good majority of those individuals that I listed on slide 2 would fall beneath that current 15, or they could anyway. So it would impact our networks significantly if the minimum wage did increase to 15. Yes, that would be impactful.
I think it's kind of a double-edged sword. I think that it will help them and help retain workers, but I also think that we have such a large percentage of folks in nursing homes and things like that are drawing Medicaid. So at some point in time, if the expenses go up accordingly, Medicaid is going to have to go up also, which is going to cost state dollars and federal dollars and all that kind of stuff. So I think it's kind of a double-edged sword, and you know, we fight every day for funding for our Medicaid folks and stuff like that. So I think it's an issue, and I think this is a perfect segue to this little gal, Gina Ernvey, has forgotten more about workforce than this whole room will ever know, is what I'll tell you. She approached me in the summer of 2018, I think, 19. She started a website for direct care workers and used some grant money that she had. She's been involved in it. Gina's on a national board, and again, let's just let her give a perspective on this. So Gina, are you there?
Yes, thank you, Chairman Carpenter. I am going to attempt to share my screen with you. Did that work? Can you hear me?
We can hear you. It may take
Okay.
a minute to load your.
Still can't view it?
We can see it.
You can't. Okay. Okay, great.
Yep, we're good.
Thank you. All right. Chairman Carpenter and members of the committee, thank you for the opportunity to speak to you today as a voice for Kansans that need the help of direct support professionals. I appear before you as both a parent and a professional with experience involving the direct care workforce. As a parent and caregiver, I have raised a daughter with Down syndrome and another daughter with a brain anomaly and mental health challenges, and I have a mother-in-law with advanced dementia. As a professional, I've worked more than 2 decades in finance and nonprofit management for senior care and care for the disabled. This life path has given me a broad perspective as both someone who uses direct care support and someone who works for organizations to provide that care. I've been blessed to see the good in our care delivery system, as well as the areas of great need. My involvement with the direct care workforce initiatives in Kansas began in 2011 when I helped the Department on Aging to secure a lifespan respite grant, and then went on to serve as the project lead to implement goals towards strengthening the direct care workforce. I'm here today to share some insight on the direct care workforce shortage we face, the dangerous trajectory we are on if we don't prioritize change now, and to share some information on current initiatives and ideas for moving our state forward. To get us all on the same page, I'll start with who I'm referring to when I'm talking about direct support professionals, or DSPs. These are the people who provide essential support that enables individuals with personal assistance needs to fulfill daily tasks and maintain their health, functional abilities, and well-being to the greatest extent possible. DSPs work in diverse settings, including in-home supports, settings in the community, and as well as facility settings. I'll refer you to the slide for examples in each of those categories. There's been much talk about the direct care workforce shortage, but what does that look like? The growing demand is exceeding the workforce capacity. When we look at some of the factors contributing to growing the demand, the first factor I have to share echoes what Janice just mentioned, and that is 1 in 4 Americans will be age 65 and older in 2016. Another factor is the increasing number of people with disabilities needing and accessing services. Between 1991 and 2014, there's been a 400% increase in individuals with intellectual and developmental disabilities receiving services. This combined with the increase in life expectancy. The life expectancy for individuals with intellectual and developmental disabilities increased from 19 years to 66 years of age between 1930 and 2013. Next, I'll summarize some key issues facing the direct care workforce. We begin with the high turnover rate that has an average of 51.3%, and this is at a time when our demand for additional workers to support both the disability and aging populations is peaking. Also, the growing demand combined with limited availability of training and education alongside increased expectations and requirements creates instability in the field. When you look at the more cost-effective in-home supports, DSPs are dealing with more significant and more complicated needs, and you couple that with the lack of supervision that is not in the home, so they don't have coworkers to turn to for support. Therefore, training becomes critical for everyone's safety. Also, another challenge, the low wages, part-time hours, shifting schedules, and lack of benefits are a barrier to recruiting and retaining workers. When you look at what our risks are for staying on this trajectory of demand outpacing supply, the risks include lack of choice, compromised independence, impaired opportunities for community engagement. Sometimes when an immediate need for services is necessary, the program with openings isn't always the most appropriate fit, and therefore individuals can end up in environments where they have less independence than what would be preferred. Other risks, maltreatment such as neglect and abuse and hospitalizations. Certainly we see when direct care workers are tired from working long hours or multiple jobs, they're more likely to make mistakes, have low tolerance for stressful situations, and certainly when workers don't know the person that they're caring for well, they may not recognize signs and symptoms of illness. Then there are the risks when there are gaps in care, including serious injury or death, or the more costly route of going with an institutionalization placement. So as we look forward to the future, we have a goal for Kansas, and that is to strengthen the care delivery system by implementing a comprehensive approach to building capacity and increasing the quality of the direct care workforce. It is to scale up interventions across Kansas to achieve meaningful improvements in direct care workers' career development and contributions to outcomes-based care for the benefit of the workers themselves, the individuals they serve, and the overall stability of the long-term care system. You will see 3 key areas of focus for strategic development. One being training and credentialing. A key strategy is to develop tiered credentialing options and career pathways for direct support professionals that provide the opportunity for growth, advancement, and specialization. A second key area is marketing and recruitment, involving developing a direct care worker recruitment and public awareness campaign, and maximizing features of the Kansas Personal Care Directory to create optimal matches between direct support professionals and direct care jobs. And a third area of focus centers around wages and benefits, with a strategy to progress towards providing living wages and access to benefits necessary to attract and retain qualified direct support professionals. We need to move towards pay that better reflects how direct care jobs are physically and emotionally demanding, and that compensates for upskilling and improving quality of care. This brings us to current initiatives in Kansas and resources that we can build upon. One initiative is WSU, our Wichita State University, is partnering with the Sedgwick County Community Developmental Disability Organization to develop a training and badge program for DSPs. WSU is also creating a structure for applied learning where DSPs can earn college credit for on-the-job experience. The Kansas Board of Regents is engaged and is strategizing for future replication of DSP training programs statewide, including high school academies. The MCOs are committed partners in the Direct Care Workforce Initiative and are funding the Kansas Personal Care Directory to match DSPs with direct care jobs. The NCOs are also currently reviewing leading edge initiatives in Arizona and Tennessee to strategize the most effective approach for public-private partnerships to improve the direct care workforce shortage. The Kansas Lifespan Respite Coalition is serving on a national work group advising a project to develop, test, and scale a DSP recruitment, training, and retention program. 3 states will then be selected to pilot the project with $10,000 in seed funding. Here in Kansas, our stakeholders are also supporting the national initiative to recognize the direct support professional as a distinct occupation title that will provide labor statistical reporting on this occupation that will help us monitor outcomes as we move the workforce strategies forward. This will be one of several steps to help professionalize the occupation and to give it the recognition that it deserves. So where do we go from here? It's become apparent to leadership across Kansas that moving forward in a meaningful way entails developing a public-private partnership. Over the past 2 decades, small-scale efforts across the nation have been made to find solutions with small investments provided by federal, state, and local governments. Most of these efforts have been grant-funded demonstration projects that don't prove fully sustainable after the grant funding ends. Implementing solutions to this crisis will require bold leadership and ongoing commitment from policymakers, state agencies, and key stakeholders. Public-private partnerships that build on common ground and break down barriers of current silos in the care system will be necessary for long-term sustainability. A strong partnership would involve the following. When we look at state agencies, KDADS, KDHE, with our training and credentialing programs on the horizon, we would be involving the Kansas Department of Education, and through our workforce issues, the Kansas Department of Commerce and the Department of Labor. We have the backing and the support of all 3 MCOs, Aetna, Sunflower, and United. We'll be involving educational institutions as we develop the training and credentialing program, and also community-based organizations and industry associations. All of these partners have a part to play in moving toward an impactful solution. That brings us to some cost data of what progress forward could look like. You will see a high-level cost projection categorized by project element. The first element listed is the addition of some project staff to help lead this initiative for the state, a staff of 3, along with marketing recruitment expenses. That is projected at an annual cost of $300,000. Another element is to retain the Kansas Personal Care Directory for the state. That comes in at $51,000 annually. The third element is about a pilot project which has been proposed that would look at the link between training and subsequent wage increases and quality improvement, as well as how effective set wage increases are as incentives. The pilot project proposed is estimated at a cost of $2 million. Compare this to what the MCOs have projected as a total cost of implementing a 3% wage increase per year for all personal care attendants under the HCBS program. That cost is estimated at $8 million. With a year-long pilot project, implementing a 3% wage increase for DSPs that participate in newly developed training, we would gather the data that would help then guide long-term strategic action plans regarding wages and benefits. And just one example to share similar to a pilot is one that I have seen in New York, where the MCOs ran a pilot to upskill entry-level workers and improve care transitions for consumers. The pilot showed a reduced rate of emergency room visits, as well as lower family caregiver strain and improved job dissatisfaction amongst direct support professionals. We are at a critical tipping point. The expansion needed in the direct care workforce is unlikely to take place without significant changes in how direct care workers are recruited, trained, and supported. We must act with urgency to ensure the health and safety of older adults and people with disabilities. A public-private partnership of key stakeholders will optimize aggressive system-level change that will generate a return on investment through improved care delivery and outcomes. I want to thank you for your dedicated efforts to navigate policies and make funding decisions that will amplify the health and well-being of Kansans. With your support, Kansas will launch a far-reaching tactical approach to remedy the care gap that will otherwise continue to grow at a detrimental pace. Your foresight and support can position Kansas to be a leader in implementing solutions for a workforce crisis that is affecting the nation at large. Thank you.
Good. Gina, thank you for that. Committee questions? Representative Ballard.
Thank you, Mr. Chairman. No, I don't have any questions, but I agree that it's time to build a strong foundation for the future of care delivery. And I think in many ways, we're going to have to look at different ways of our delivery service, whether it's through telemedicine or other means. But I enjoyed your presentation, and you raised some good questions, good things to think about. And one I'm looking at is Kansas Lifespan Respite Coalition is serving on a national work group advising a project to develop, test, and scale a DSP recruitment, training, and retention program. 3 states will be selected to pilot the project. And I think those are the kinds of projects I think we're going to have to initiate. And I just want to thank you very much for this.
Thank you.
Representative Donahoe.
Thank you, Mr. Chairman. This is just a statement. I think one of the things you mentioned, I think it was in 2039, that the elderly population will be pulled out of the younger population and everything. I don't think there's any way in the world that we're going to resolve the problem with the potential solutions you're looking at. But I think there's a pretty simple solution out there, and that is, when you take a look at the world, the United States is a very old country. Its people, they're very old. But if you take a look at the rest of the third world countries and this and that, they're very young. And we're going to have to go out and bring people in from those societies to become caregivers, I believe, because there's simply no way the American people are going to be able to resolve this on their own. There's just not the people, and there's not the money. But if you have a situation where you can go into these countries, set up training programs, educate people and taking care of the basics as you have to, you also have the ability to have them live in home, where they can come into a person's home. Many of these people own homes yet. Many of them want to stay in their homes, but they're forced out because they can't take care of themselves. So the whole point is, obviously, I think there's a very good solution out there. We just got to go outside the normal thinking and say, this may be the answer to our problem. Thank you.
Very good. Thank you. Any other questions, committee? Very good, Gina. It looks like you're off the hook. Thank you for doing this and doing what you do. I know you've been doing a lion's share of work on this, and the MCOs have been helping you out, and we're going to try to make some sense of this and see if we can't get something constructive going. So thanks again. Any last words from you?
No, I just appreciate the closer look you're taking at this. In response to the last comment, I do fully agree that creating a pipeline is an effort that we're looking at several strategies to create that ongoing onboarding of young people by focusing on some incentives for giving them college credit for work in the field so that we can continue that pipeline of workers that are going into a lot of high demand fields. Rather than working at retail and other jobs during college, they can be serving through a direct care role. And so there is a lot of what was said that is true as a very plausible strategy as we work towards creating a pipeline. So Thank you for taking this closer look today. I appreciate your time.
Thank you. Okay, committee. Any other questions? I just, again, Ballard told me, and I just think that this thing is going to, at some point in time, people are going to go, what are you guys doing after, before it becomes a crisis? That's what I'm trying to work on, and it's a great big thing, and it's very hard to get your arms around, and sometimes you just want to just avoid it. And that is not going to help either. So, anyway, that's all I have. Committee, anybody online or anything have anything to add?
Mr. Chair, this is Susan.
Yes, Susan.
I just, I just wanted to I just had to make a comment. I would not want us to see a, setting up something like an indentured servant type of a situation with looking at folks from other countries. I would hate to do that. I'm also, very well aware, although I don't have any data to back this up, but maybe our two presenters, could maybe do some research on that. And to look at, not only are we looking at folks that provide long hours of service. If you look at CNAs alone, they just, in my experience, they provide, it feels like the lion's share of the work of caring for our loved ones in nursing homes or some type of facility. And, but it also seems to me that we have a lot of people of color who are able to do those types of jobs. And they are, people that, CNAs that work 2-3 jobs, there are no benefits. And these are the same workers, if we would pass Medicaid expansion, they would be eligible for that. And so, looking at these salaries for CNA workers who do so much of the work is a serious endeavor that we need to look at those salary increases for them. If we want to be able to have people who are able to work and live and raise a family and not have to make some hard decisions regarding their own health care or feeding their family, we've got to pay living wages. And I really think CNAs in particular, because of the subject matter that we're talking about now, really need to have that kind of a salary. So, thank you, Mr. Chair.
Representative Donahoe.
Right, I never intended these to be indentured servants. I intended that they would be people who we'd go out and get that would be interested in coming to America, which it seems a lot of people are, and we pay them a wage like we'd pay anybody else, and they want to go on to citizenship and all those things. Yeah, provide it, because we're going to have people come into this country to assist us in our workforce. And this would, in my opinion, solve a problem and be an excellent way to do it. Thank you, Mr. Chairman.
Committee, any further questions? Well, thank you, and food for thought. My door's open. If you've got any thoughts on this issue, it's not going to go away. So thank you. With that.